Okay, so we saw how some of the deficits or changes that someone has when they have dementia can affect their physical and cognitive abilities and their day-to-day functioning. And we will look at more of those difficulties. But first, we're going to introduce a couple of terms that we use as healthcare professionals when we're trying to better understand daily activities. So these terms are what we call ADLs and IADLs. So what are ADLs? So ADLs are activities of daily living. They're necessary for someone's basic day-to-day functioning, and they're self-care tasks that are done on a daily basis. So these are things like getting washed or getting bathed or bathing, getting dressed, grooming, feeding, toileting or getting to and from the bathroom, and physical walking or physical mobility within someone's environment. So as you can imagine, all of these activities, to some degree, need to be completed on a daily basis and sometimes more than once a day. Some people have, there's variation in people's preference of how and when these are done, but in general, these are done every day. So instrumental activities of daily living are the tasks that we do sometimes every day, but often less than every day, and they're required for independent living. They do have a higher demand for both physical and cognitive abilities. So we can understand that for people with dementia, IADLs start to be affected first over ADLs because they are more complicated tasks to complete. And they do require a higher level of judgment, planning, organized thought, and complex thinking. So these are things like being able to drive, managing your finances and complex financial management, taking your medications, shopping or getting groceries, and preparing meals. So as we can imagine, so if a caregiver is involved with people with someone with dementia, helping someone with their IADLs is usually less stressful than helping someone do their ADLs. So now we're going to jump to person-centered care. So what is this? So person-centered care is a philosophy of care that recognizes that individuals have unique values, personal history, and a personality, and that each person has an equal right to dignity, respect, and to participate fully in their environment. So when helping to create dementia-friendly communities, this approach to care is important. We're trying to optimize a person's autonomy and independence in their daily routine as much as possible and for as long as possible, but also while supporting their caregivers. So it recognizes that individuals have unique values, history, and a personality. It also recognizes that everyone has the right to make decisions when possible, or at least be included in decision making as much as possible. This can become complicated for someone with dementia who relies on others to help with their care, as decisions often impact others as well. But we try to keep this philosophy at the core of how we provide education and care to those with dementia and their partners in care. So why is this important? So we know that as dementia progresses, the person will lose their abilities to complete their IADLs and ADLs. So we know that more help will be required as the person progresses through their dementia. So the safety of the person with dementia and the caregiver are very important, but it's important to keep the philosophy in mind that as much as possible, optimize the remaining capabilities or independence of the person with dementia so that we're not either jumping in too soon to help when we don't need to, or we're not painting with a broad stroke that people with dementia always need help with everything. So the supports that are put in place ideally should be targeted towards what they're having the most difficulty with, and still capitalize on what they can still do. So I often say, don't let what they can't do interfere with what they can do. So for this education workshop or module, we're really focusing on the task of toileting. And now we see when working in practice and also from the literature that this task is very challenging for caregivers and the person with dementia. And it's often considered the most challenging. So throughout this workshop, we're going to be using the toileting scenario and assisting someone to and from the toilet to help highlight some important strategies that can help. So we're hoping this will alleviate a little bit of stress that caregivers have when helping someone with dementia get to and from the bathroom. So we see how difficult toileting is for caregivers in practice, but again, there's lots of evidence in the research literature that tells us as well. So this is really hard work, and here's just a few articles that highlight this. So caregivers place high importance on preserving a person's ability to use the toilet without accidents over any other daily activity, and this makes sense. And then again, no surprise, managing incontinence is a major source of stress for caregivers. I'm just going to digress a little bit to explain what incontinence is. So incontinence means when someone loses control of their bladder or bowel and it leads to an accident. I know sometimes I say that word a lot as a healthcare professional, and some people stop me to ask, what is incontinence? So we're going to be talking a lot about incontinence throughout this presentation, so it's important to understand that it is when someone loses control of either their bladder or bowel. And there's lots of reasons why incontinence occurs, but we'll focus on ways to hopefully avoid this as much as possible. So more research includes the inability to use the toilet is a strong predictor for hospital admission and nursing home placement. And this, again, is no surprise. This can be often a tipping point for caregivers because this is a tough job to manage at home and still feel motivated to continue to care for someone at home. And then also, from the perspective of the person with dementia, their ability to get on and off the toilet is associated with agitated behaviors. So if there are ways to look at facilitating, helping the person get on and off the toilet so that they feel more independent, that can help avoid some agitated behaviors and causing the person and the caregiver to become upset. There is some evidence for using timed toileting or scheduled toileting to reduce incontinence. However, this is a strategy that may or may not work. It depends on the situation and the person, but it might be worth trying, especially for those people with the later stages of dementia. So here are some basic starting points when we think about helping someone with toileting. It involves many steps and things to consider. So it's not just sitting on the toilet, doing your business, and then wiping. There are multiple steps involved from the start when the person identifies or doesn't identify that they have to go, to standing from the toilet afterwards, things like getting to the bathroom, managing any clothing involved, sitting down, actually going, the wiping part of it, and then managing the clothing again. And that's assuming the person is using the toilet in the bathroom. So there's lots of steps involved. It's important to know the person. Do they tend to use the bathroom at particular times of day or night? Are they a very private person who will become upset if a stranger helps them? How has their dementia or other conditions affected their ability to use the bathroom? Can they orient to the bathroom? It's important to know what they're still capable of and how much they can do on their own. And this is looking at the task of toileting as a whole. So they may still be able to reach back and sit down onto the toilet by themselves, but may need a little bit of help with wiping. So if you can understand what they can still do for themselves, that can help you as a caregiver not to jump in to help as much. So we want to set the person up for success as much as possible. So for example, if we know they struggle with understanding more than 2 or 3 steps at a time, for example, we might say to them, we're going to go to the bathroom, stand up, walk over here, sit down, and do this. If we give them all at once, that may be too much information for them. So consider setting up your instructions as one step at a time for the person to understand. And as always, with the person-centered philosophy, always try to treat the person with respect and dignity. So is it possible to leave them alone on the toilet for more privacy while you wait outside? Or could a towel be draped over their lap to preserve privacy? So thinking about all those strategies as well. So now I'm going to introduce the clinical frailty scale. This was developed here in Halifax by Dr. Rockwood and his researchers. It aims to understand the aging process better and how it affects people's ability to function in their day-to-day. It's called the clinical frailty scale. So there's lots of importance to discuss with this scale. However, for the purpose of this presentation, we'll just focus on a few relevant points. So on a basic level, frailty from this view means that as we age, we accumulate conditions that will lead to deficits in our ability to be independent and function as we used to. For example, having arthritis, diabetes, congestive heart failure, lung disease, a mental health illness, dementia, or any other medical condition will impact our abilities over time. Frailty level could be due to both physical deficits or cognitive deficits, or both. A person with dementia will eventually have both cognitive and physical impairments that will affect their abilities in ADLs and IADLs, so they will become increasingly frail as the disease progresses. So here is the clinical frailty scale. So generally people progress through the stages with increasing frailty as we age until the point of end of life. We may end up staying in one stage longer or shorter than the other, and ideally we'd spend less time in the extreme stages of frailty and more time in the healthier stages before our end of life. With dementia, this can be helpful to understand because it helps us predict what is coming next and how can we care plan to prepare the person and ourselves as caregivers so that we're not as surprised when the person loses more abilities. In turn, this helps to optimize both the person's quality of life and the caregiver's quality of life as they go through this journey. So one of the other points is that it makes us realize that chronological age is less predictive of negative health outcomes than our actual level of frailty, or how many multiple conditions you have affecting your independence in your daily activities. So the scale here, it says, how fit and independent are you? So some people prefer to use the language, how fit or how robust are you, rather than how frail are you. Either way, a person will be less dependent on others the more fit they are and the longer they can stay at fitter levels on the scale. If a person is diagnosed with dementia, the stage of dementia will correspond to the level of frailty. So if I have mild dementia, I would be considered at least at mildly frail on this scale, and we'll see why this is in a minute. So if we break down the scale, it starts with someone who is very fit. These are the people who are the fittest for their age. They're active, they're energetic, they're motivated, they're exercising almost on a daily basis. People who are well have no active disease symptoms but are less fit than very fit people. Often they exercise on a seasonal basis or less than daily. Someone who's managing well is someone whose medical problems are well controlled but may not be as active beyond routine walking. So these people do not have dementia, and they are still very independent with their ADLs and IADLs. When someone becomes vulnerable, they may not be dependent on others for daily help, but often their symptoms will limit their activities. They often find themselves being more tired during the day or being slowed up. They might start using a cane or some sort of aid to help them walk. Now, someone who's mildly frail will start to have difficulties with their IADLs, those higher complex tasks like finances, driving, medication management, or meal prep. So these people are still independent with their ADLs and getting to the bathroom. And so someone who has mild dementia would be considered to be mildly frail. Then we get to being moderately frail. So this means you need help with all of your IADLs in some way. So you may have someone doing your groceries, managing your finances, doing your housekeeping, providing some supports with medication reminders, or doing driving for you, or sometimes more complicated meal prep. At this stage, the person is still able to do basic activities of daily living, but they're starting to have difficulties with things like toileting, bathing, and dressing. They may need cueing to help them get dressed. They may need some cueing or some physical assistance to get to the toilet. So at this point, this is where the caregiver is really starting to help with things like bathing and dressing and getting to the bathroom. And a caregiver may want to consider having some home care or private care or some outside supports to help this person at this stage. Someone who is severely frail are dependent on others for all of their IADLs and ADLs, including toileting. They usually have incontinence at this stage with both bowel and bladder. They likely rely on a wheelchair to get around their home or someone to help them stand or walk a few steps. So someone who is very severely frail is completely dependent on others and is often bedbound. End of life is approaching and they will unlikely recover from a minor illness. People experiencing late stage dementia would be considered in the severely and very severely frailty levels. So when someone is at these levels, a caregiver or caregivers involved are doing a lot and stress is often high. So this is where if you haven't sought out resources like home care, finding out what potential insurance companies will cover for adaptive aids or assistive equipment, seeking out if you can have physiotherapy or occupational therapy come in to do an assessment, seeking out some respite care so that the caregiver can take a break. You really want to be seeking these things out at least at these stages, if not at more moderately frail. So one of the main points is as someone progresses through the frailty scale, or if they have dementia, we know that they're going to rely more on others with their daily activities over time. So that means the need for a caregiver to help will increase as a person's frailty increases. So it's up to us as caregivers to try our best to catch up to their adjusting or to their changing care needs and adjust to that as best we can.